Hello, I'm Dr. Nilesh Kumar, and today we are going to discuss about how a beginner can tackle small pupil. This all videos are being recorded in my first year of practice doing my Phaco and a few cases of SICS. Small pupil come in different types and of different size, and each one is unique in its own way and require a different solution each time. So the first go-to therapy is use of Midriatic, that is intracameral. The most common brand is Phenocaine, no financial interest. Even after Phenocaine, when it is not dilating, then the second option is to fill or overfill the anterior chamber with viscoelastic substances, and that way you can have a decent dilatation and go ahead. But when the pupil is stuck onto your anterior capsule, you can see then the Phenocaine won't work. You have to still instill it. As you can see, when I do a synocolysis, then I inject Phenocaine and there is a minimal amount of dilatation. Then you inject Visco. Before injecting Visco, we have to stain the capsule, otherwise the capsule won't take stain once the viscoelastic is over it. What you have to do is go below the pupillary plane and do the staining. Otherwise, you are in the AC, you only stain the capsule that is visible, and once you dilate the pupil using this Y retractors, as you can see, we go from the opposite side and stretch it. It is stretch pupilloplasty. Now you can see the anterior capsule is completely stained. If you just are in the AC, then you will only get a central stained capsule and white capsule, unstained capsule all around. Now coming to the fourth option. This is a decent enough capsule if the cataract is not that hard, but this is a black cataract with a very large nucleus, and I have to convert it into SICS midway. I thought that I'll start, but the pupil was not dilating, so I converted it into SICS at that point before performing the Rexus. So I thought that I'll use iris hook in this case. Iris hook is quite cumbersome to use, but it is very helpful in these type of cases where the nucleus is way too large for any other pupil expansion device. So in this case, you just inject some viscoelastic below the pupillary plane so that you get a decent gap between the iris and the anterior capsule, and then you engage your hook in that area. You enter with 4 iris hook I have used. You can also use an additional 5 to make it a pentagon. That way you will get even more exposure, but I thought 4 was decent enough, and then I proceeded with capsular access and completed the surgery. It all went well. Now in Phaco, the most common thing that I use and most of us nowadays use is BX ring, that is by Medinman devices, no financial interest. So how to place this BX ring is a challenge. What you do is place your 2 flanges in such a way that it can be accessed from a side port, so that you have a minimal amount of entry and rotation to be done. So you engage one flange, and then you pull and engage the second flange from the same side port, and then you go from the opposite side port and then pull the BX ring and then engage the third flange. This way 3 flanges are below the pupillary plane and 3 above, and you get around 5.56 mm of exposure. Same thing can be done in this case when the pupil comes down intraoperatively. You have done Rexus, so there is a chance that your BX ring can engage the Rexus margin and tear it. So what you have to do is inject some viscoelastic below, then engage one flange and go well beyond the pupillary the Rexus margin. You can see that the Rexus margin is below and your BX flange is clear of it. That way you are sure that you are in the right plane, and then just do the same with the second flange. When 2 flanges are in plane, there is a minimal risk that your third flange will go and engage the capsular rim, and that way you can proceed. Now some cases like in this, you can see there is an eccentric pupil. There is some amount of dark pigmentation in the angle base on the side where it is eccentric. In such cases, what you have to first try is to engage the BX ring. I did that first, but two flanges were decently placed, but when I started to pull for the third, to engage the third flange, you can see there is an excessive amount of tag on the third part, so I have to use a wire retractor again to do a stretch pupiloplasty and then engage the third flange, and then I had a decent access to go ahead with this surgery. So sometimes you have to do a mix and match in such scenarios, but in most of the cases, once you gain some experience dealing with small pupil, a pupil of this size, that is around 5.5 millimeter, if you are able to perform a good capsular access, you don't need any devices. So this is what is being done here. A decent 5.5 mm access I am able to get, and can see the capsular rim also. So in such cases it's very easy, you just do a good hydro procedure. The main thing is, in such cases you have to be in the central safe zone, you don't have to go into periphery at all, otherwise it becomes a mess, because you will engage your pupil, the iris into your probe, and then you can do a lot of damage, and the pupil can become really small, bleeding can happen. There are multiple issues that can come. So better to be in the central safe zone and use your second instrument to feed even the epinuclear plate into your probe. So once the epinuclear cleaning is done, then you can go ahead with your bimanual cortic aspiration. In these cases, this bimanual aspiration is a very good option rather than a coaxial irrigation aspiration. So now once we have placed the IOL, what we have to do is again use a wire retractor and see that the IOL is in back, because you can't see the capsular ring. So you have to make sure that your single piece IOL is not in the sulcus. So that's what happened. I saw that it is in the one of the haptic is in the sulcus, and then I just dialed it and placed it into the capsular rim. So that is all that I think is required for a beginner to tackle small pupil. Thank you for your kind attention.